So I'm very excited to be presenting the results of a phase 1 trial. This is an investigator-sponsored trial titled the combination of duvelisib and venetoclax for patients with relapsed refractory CLL or SLL. Currently, there are a variety of drugs that are approved in the relapsed refractory setting, including both duvelisib and venetoclax, which can be, in the case of venetoclax, combined with the drug rituximab. And while each of these drugs are approved as monotherapy, this is the first trial that's combining these two agents together. And while responses can be good for many patients, there are subsets of patients, especially those with high-risk features such as P53 mutations or abnormalities, and those who have progressed on prior Bruton tyrosine kinase inhibitors that have shorter durations of response to those agents when used alone. So in this trial, our hope was to combine two efficacious agents with the hopes of having a deeper and more durable responses. So this was a phase 1 study, so our main primary endpoint was to determine the maximum tolerated dose of venetoclax to be used in combination with duvelisib, as well to determine the recommended phase 2 dose to move forward. What we found was that the way the study was designed was both drugs were given in combination. Duvelisib was started on day 1 and venetoclax was added in on day 8. Because of the potential of drug-drug interactions, we started at a lower dose of venetoclax than is typically used at 10 milligrams, and this was for close monitoring for tumor lysis syndrome, which is a known side effect. Those patients were ramped up to one of 3 dose levels in the inpatient setting, and both drugs were given for a total of 1 year together. At the 1-year mark, if patients had undetectable MRD, they had the option of discontinuing all therapy, which was an exciting option for patients. And if patients had detectable MRD, they would continue on venetoclax monotherapy at that point. What we found was that the combination was generally well tolerated. Patients had, the most common side effects were fatigue, anemia, and thrombocytopenia, and the most common grade 3 side effect was neutropenia. Despite high rates of neutropenia, rates of infection and febrile neutropenia were low with this combination. There were no tumor lysis syndrome seen, which was good given the potential for drug-drug interaction. We also performed PK studies that showed no significant drug-drug interaction. Some patients who were treated with duvelisib did require drug holds because of toxicity, including diarrhea or elevated amylase and lipase, but those patients were able to be successfully treated with steroids and eventually resumed duvelisib therapy. Although the follow-up is quite short at this time, this does seem to have early signs of activity in a high-risk patient population. In this study, we had all patients with unmutated IGVH mutational status. About a quarter of patients had deletion 17p, which is a high-risk marker, and over 80% of patients had been treated with prior BTK inhibitors. And of this group, of the 12 patients that enrolled, 11 patients have had response, though follow-up at this time has been short. And of 2 patients that have completed the 12 cycles of combination therapy, 1 patient had undetectable MRD and was able to discontinue therapy. So we're really excited about the next phase, which is going to be the phase 2 portion of the study to further evaluate for efficacy of the combination. The phase 2 study will also include a cohort for Richter syndrome, which is when CLL transforms to a more aggressive diffuse large B-cell lymphoma phenotype, and so that's a great unmet need in the field and difficult to treat population, so we're excited to be including that population in the phase 2 trial as well. There's also some data that's going to be presented at ASH this year that this combination may be efficacious in PDX models or mouse models. So that trial is now open and accruing in a multi-center trial. So we're excited to see the results and see if it's feasible for patients to potentially be treated with an all-oral and possibly time-limited regimen.